welcome to this special meeting, Neurology and Cardiology from Hospital Israelita Albert Einstein. This meeting will be today in English because we have a very special guest, Professor Mitchell Elkine, the immediate past president of the American Heart Association, professor of neurology and epidemiology, and head of the Division of Neurology and Clinical Outcomes Research and Population Science. He will have a presentation about atrial cardiopathy and stroke, and after that we will have a discussion. And to discuss it, we have in this meeting Dr. Gisele Sampaio Silva. She's a neurologist and clinical trialist at the Academic Research Organization here in Hospital Israelita Albert Einstein, and Ayrton Roberto Massaro, neurologist at our institution. To moderate this discussion, we have here Poliana Toledo Pisa, and she's a neurologist and coordinator of the Neurology Intensive Care Unit. So thank you very much, Professor, and please, we are very, very excited to hear you.
Well, thank you so much, Marcelo, for the kind introduction, and thank you to yourself and Poliana and Giselle and Ayrton for inviting me to speak today and for being part of this discussion. I've known Ayrton since, I don't know, early 2000s, probably before that, 1990s, and it's great to catch up again here today. And I guess I'm kind of glad that I don't, in a sense, I'm not there today to watch this battle between the neurologists and cardiologists. I can say my piece and leave you all there to, you know, duke it out, and I don't have to get hurt at all. So thank you for that. And I think it's a great idea and very exciting to have cardiology and neurology together to talk about stroke. I think there's just been such a tremendous amount of information and research and advance in the area that really connects heart disease and brain disease. You know, if you think about the work on just cardiovascular risk factors and how there are also risk factors for dementia, all the work around PFO and whether we should close them or not, and stroke. And of course, atrial fibrillation, which is also now seen as a risk factor for dementia. And then this topic that we'll talk about today, which is atrial cardiopathy. And I look forward to the discussion because I think cardiologists and neurologists have a very different take on this topic as well. So I look forward to hearing what you all have to say about it. And as I think Marcelo mentioned, I was just the president of the American Heart Association up until the end of June. And one of the things I had hoped to accomplish during my tenure, during my year as president, was to facilitate interactions between cardiology and neurology. And that was my hope going into the year. And then, of course, COVID hit. And so a lot of our attention was focused on COVID during the last year instead. And I know you all are no strangers to that problem as well. And I mean, it did turn out, of course, that there was a lot in COVID for both cardiologists and neurologists. So we've certainly been busy and continued to work in this area. But we won't go there today. We'll focus instead on this topic of atrial cardiopathy and stroke instead. So again, thank you for having me. And I will, hopefully you all can see the slides, and how come it's not advancing? Let's see. Okay, so here are my disclosures, a couple of which funding from BMS Pfizer for a trial that I'll talk about. They're actually providing the drug apixaban for our clinical trial on atrial cardiopathy, and also some funding from Roche towards that trial, the Arcadia trial, which I will tell you about. So this is what I'd like to do today. We'll talk a little bit about the topics of cryptogenic stroke and ESUS, embolic stroke of undetermined source. We'll talk about atrial fibrillation, and then we'll talk about atrial cardiopathy, and finally, clinical implications. So here's an example of this entity of cryptogenic stroke. And in the upper right-hand corner, you can see Dr. J.P. Moore, who was a mentor to both me and to Dr. Massaro at Columbia. Dr. Moore is still practicing at Columbia. But he described back in the 80s, I think, this entity of cryptogenic stroke. And here's an MRI scan from a patient with this condition. This is a 57-year-old man who had left arm and hand weakness and numbness. And as you can see on the right side of his brain, that bright signal on this diffusion-weighted scan is a tiny little infarct. Surface of the brain, it's due to an occlusion of a distal vessel. And when a neurologist sees this, we think immediately of embolism, generally from the heart. And this patient was thoroughly evaluated. The only cause identified was a patent foramen ovale that he had. And here's the kind of traditional definition of cryptogenic stroke or ischemic stroke of undetermined origin. This definition comes from the TOAST trial, where they classified strokes. And they said it was a brain infarct that's not attributed to a definite source of large vessel atherosclerosis, definite source of cardioembolism, like atrial fibrillation or a clot seen in the heart, or small vessel disease. And this was either in the presence of a complete evaluation or an incomplete evaluation, or if there was more than one competing cause. So for example, if somebody had atrial fibrillation and carotid stenosis on the same side, they'd be called ischemic stroke of undetermined origin as well. But this definition is problematic because, as you can see, as I highlighted there, it included incomplete evaluation. Now, obviously, if you don't test for something, you're not going to find it. And so this definition has sort of been eclipsed recently by this other definition, the ESUS definition, embolic stroke of undetermined source, which was first described in a paper by Bob Hart and Ralph Sacco and others back in 2014. And here you can see to call a patient's stroke ESUS requires that they've actually had the full evaluation. They don't have a lacunar stroke. They don't have stenosis of at least 50% in either the extracranial or intracranial vessels. And remember, we often don't look at the intracranial vessels. So the ESUS definition requires that we also look at the blood vessels inside the head, and the patient has no major risk cardioembolic source of embolism based on an echo and at least 24 hours of monitoring. So we've excluded atrial fibrillation, prosthetic valves, low ejection fraction, etc. And no other specific cause, unusual things like vasculitis or dissection. And it turns out that this entity of unexplained stroke is actually quite common. This is data from the Northern Manhattan study. Dr. Massaro was reminding me before this talk that he was there when the study began, working with Dr. Sacco, who's now the chair of neurology at the University of Miami and probably well known, at least to the neurologists in this group. He was also a former president of the Heart Association. And in our data in Northern Manhattan, in our population-based study, even after a full evaluation, about a third of patients turned out to have strokes of unknown cause. Now, one thing I think it's worth thinking about is, well, I'll just spend a minute or two talking, this is really probably more for the cardiologists perhaps, hopefully the neurologists are familiar with this, but patients with ESUS, the ESUS, being ESUS or not, is not determined by the size of the stroke. So on the left there is the patient who I just showed you, the 57-year-old man with a small superficial infarct on the right. And on the left is a classic lacunar infarct, right? This is a 48-year-old Black woman who had a history of hypertension, had not been treated, and she presented with rapidly progressive right hemiparesis. And you can see that she has a small infarct deep within the brain in the internal capsule on the left side, classic lacunar infarct. These strokes are about the same size. And so size does not determine whether something is a lacune or cryptogenic stroke. You can have a tiny stroke on the surface of the brain, and that can be due to an embolism. And sometimes we'll hear people, often radiologists, will say, oh, the person has, they would call that one on the left a lacunar stroke because it's small, but size does not determine the cause of the stroke. It's really the mechanism. Here's an example of a large stroke, which itself turned out to be embolic stroke of undetermined source. This was a 78-year-old man with a history of hypertension and rheumatoid arthritis. He presented with acute confusion. He was actually evaluated as an outpatient, saw his doctor, a little bit confused, but walking, talking, on the surface looked fine, went for an MRI scan. This MRI scan showed this abnormality and then got sent to the neurologist, who noted he had a very mild left hemiparesis, and of course he has a fairly significant burden of infarct in the right hemisphere, both superficially and down deep. And so here you can see that you can have a large stroke from ESUS as well. He actually ultimately turned out to have atrial fibrillation on long-term monitoring. So ESUS is defined not by size, but by its location or mechanism. And so the lady with the lacunar stroke, as neurologists, we think of this as being due to a blockage in one of the small penetrating vessels deep within the brain. Our first patient we think of as being due to an occlusion in a distal blood vessel, one of the branches of the circle of Willis that can lead to a superficial infarct. And then the 78-year-old man has a combination of superficial infarcts and deep infarcts due to occlusion at the middle cerebral artery stem, leading to blockage of several of those little penetrating vessels at the same time. So this leads to a large deep infarct rather than a small deep infarct, sometimes called a lagoon as opposed to a lacoon. That may not translate well, I don't know. But anyway, you can see that these are the different mechanisms of stroke that can occur. The other thing I like to remind people when we think about cause of stroke and cryptogenic stroke and ESUS and so forth, is that when neurologists see a patient with a stroke, we're really trying to resolve what happened along two different tracks at the same time. We look for the proximate cause of the stroke, as well as for any risk factors that the patient may have. So, in other words, just because somebody comes in and has a carotid stenosis that explains their stroke, we don't just say, oh, you just need surgery or a stent, and do that and send them home, and we're done. We're also managing their risk factors, right? Controlling their blood pressure, controlling their lipids, telling them to quit smoking, eat right, and so forth. And by the same measure, if somebody comes in with an unexplained stroke and they turn out to have diabetes, we don't just stop there and say, oh, you have diabetes, we don't need to do anything else. No, we also look for what we would call the proximate cause, or the thing that made that stroke happen, meaning carotid disease, atrial fibrillation, and so forth. So we're always doing both of these things at the same time. Now, there's some interesting data that's emerged in this era of thrombectomies for acute stroke that does suggest that this idea of embolic stroke of undetermined source, these patients really do have emboli coming from the heart. This is data that came from Germany, where they looked at the blood clots that were extracted from patients having acute strokes, pulled out of the middle cerebral artery, 30 or 40 patients they had. And they looked at the presumed cause of stroke in those patients. The lettering is small here, but on the left you have atherosclerotic, this is cardioembolic, then other explained causes, and then cryptogenic over here on the right. And if you look at the characteristics of the clots, which are divided up by platelets, white cells, and red cells, that's why it's this triangular shape here, the clots in those with cardiac embolism look very similar to those with cryptogenic stroke, consistent with this idea that these are in fact emboli from the heart, even though the proximate cause has not yet been identified. So this is indirect evidence that ESUS is in fact a cardioembolic source. Now, when we think about ESUS, there are many different potential causes, and each one of these topics could be, a lecture unto itself. So we're not going to go into all of these, of course, but this is exciting stuff for the neurologist who then gets to cogitate, think about, and evaluate a patient for all these causes. And then, of course, there are many other unknown causes that haven't been discovered yet. And I would say one of the most recent ones of these that we've learned about is COVID, right, which can be a cause of thrombosis and strokes that are unexplained. But let's focus today on this issue of atrial cardiopathy, which again should be of interest to both the neurologists and the cardiologists. And here's a brief history of atrial fibrillation and stroke. Neurologists know this man. I'm not sure if all the cardiologists do, but this is C. Miller Fisher, who I think most of us would agree is sort of the father, the grandfather, if you will, of vascular neurology. And he's the one who initially made the connection between atrial fibrillation and stroke back in the 70s and 80s. And if there's time at the end, we can talk about some of the fun stories he tells about that. In the 80s and 90s, of course, warfarin was shown to be superior to aspirin to prevent strokes in patients with atrial fibrillation. More recently, people began to appreciate that paroxysmal atrial fibrillation was also associated with stroke risk, and that the harder we look for atrial fibrillation, the more likely we are to find it. And now, in the latest century, newer oral anticoagulants have become available. They have many advantages. We've learned a lot about risk stratification using things like CHADS-2 and CHADS-2 VAST scores, and then this concept of atrial fibrillation burden as well. And I think most of the cardiologists here probably think about atrial fibrillation in these various categories: paroxysmal, persistent, long-standing persistent, permanent, and then this maybe old category people don't use so much anymore of lone AF. To a neurologist, though, the most interesting kind of atrial fibrillation is occult atrial fibrillation, right? When a patient comes in with a stroke and they have known AF, they have a history of AF for years, or there's AF seen on their EKG when they hit the emergency room, we almost, we sort of quiet down. That patient becomes less interesting in a sense because we know what the cause of their stroke is. But occult atrial fibrillation is AF that eludes detection during the initial evaluation. They may have paroxysmal AF, but it occurs so infrequently that it's not easily detected. And those episodes can be extremely brief, and I think there's a lot of debate between neurologists and cardiologists about how long an episode has to be before you'd be willing to call it a cause of a stroke. Why does it matter? Well, it matters because finding atrial fibrillation leads to treatment with anticoagulation, which is much more effective than placebo or even than aspirin in preventing recurrent stroke. And in fact, it's the only common stroke mechanism for which anticoagulation has been proven to be effective. But it can be hard to find it. It's frequently paroxysmal. 25% of patients with atrial fibrillation first present with their AFib at the time of a stroke. In other words, it's a neurological presentation that leads to the identification of their heart disease, their AFib. And it can be hard to find because it's so infrequent, occurring less than 10% of days on monitoring, and often with very low burden of atrial fibrillation. We do know that the longer you monitor people, not surprisingly, the more likely you will be to find atrial fibrillation. But how long should we monitor? Well, there are a couple of studies that have addressed this. There have been a number of observational studies that have shown that you can detect atrial fibrillation with 30-day event monitors or more in 25-30% of patients. But nobody had really shown what the comparison is between a standard evaluation and a longer-term monitoring. And so there are two trials that are worth knowing about. One is the EMBRACE study. This was a Canadian trial in which they enrolled about 570 people with cryptogenic stroke, or TIA, within the last 6 months. They had to be over age 55, and you can see their mean age was 73. They had a negative evaluation, although only 8% underwent a transesophageal echo. And they compared standard monitoring, meaning 24 hours of telemetry in the hospital, to 30 days with an event monitor. And their primary outcome was just 30 seconds of AFib detected by 90 days. And the AFib wasn't always detected on the, let's say 24-hour monitor. In some cases, there might have been abnormalities seen that led to more frequent EKGs or checkups and so forth, versus the 30-day monitor. And there was a dramatic difference in the detection of atrial fibrillation with the 30-day monitor, 16% versus 3% at the end of the 90-day period. That's for a 30-second atrial fibrillation bout. If they looked at a longer window of 2.5 minutes, there was still a highly significant difference. Same for any atrial fibrillation. And not surprisingly, those who had the 30-day monitor were found to have AFib were more likely to get anticoagulated. The study did not look at recurrent strokes as an outcome event. It wasn't powered to look at outcomes. It was powered to look at detection of atrial fibrillation. The second trial is the CRYSTAL AF study, which was an industry-sponsored study by Medtronic, and they looked at 440 cryptogenic stroke patients. Again, no history of atrial fibrillation. They could be younger, as young as age 40, so they were on average 10 years younger than the EMBRACE population. And in this case, everybody got a TEE to rule out a clot in the heart, okay, or other cause. And in this case, they compared the 24-hour monitor, just like an EMBRACE, but to an implanted cardiac monitor. It was the older device that they had, and that was in for up to 3 years, right? The battery could last for up to 3 years, the Reveal XT device. And they looked at, again, a primary endpoint of AF of at least 30 seconds. And they looked at 6 months, but then continued to follow people beyond that time. And just like in EMBRACE, they found a much higher likelihood of detection of atrial fibrillation as they followed these people. And at 6 months, there was a 6-fold increase in likelihood of detection of atrial fibrillation. And if you looked at 12 months or out to 3 years, the differences became even more dramatic, such that by the end of 3 years, there was a 30% likelihood of finding AFib in those with the monitor versus 3% in those with standard of care, a 10-fold increase in detection of AF. Dramatic difference. And in this study, again, they were not powered to look at clinical events, at recurrent stroke events, but as a secondary outcome, you can see here that there was a trend towards an increase or a decrease in risk of recurrent stroke in those who had the monitor, presumably because when AF was detected, they got anticoagulated and it prevented a recurrent stroke. But again, in this study, the study wasn't designed, neither of these studies were designed to answer the question of whether the monitor would reduce clinical events in the long term. So these two trials, EMBRACE and CRYSTAL AF, show us that a 30-day monitor is better than 24 hours. They show us that a monitor that can stay in for 3 years is better than 24 hours, but there's no head-to-head comparison of the 30-day versus the long-term monitor. Similarly, it doesn't tell us about clinical outcome events, and so for that reason, the clinical guidelines haven't really changed to say you must do a monitor in these people because there's no proof it reduces the clinical outcomes. So those are still unanswered questions. So that's all well and good and interesting about atrial fibrillation. But let's look at this another way. If we look at the results from CRYSTAL AF, they show that at 36 months, 30% of people were found to have AF. But one could ask the question, well, what about the other 70% of patients? What else might be out there that could have caused their stroke? And so this has, in a sense, led us to go back and look at the ways in which atrial fibrillation may lead to stroke and kind of think a little bit more carefully about our assumptions about those mechanistic connections. So first of all, as many of you probably know, there's no clear temporal relationship between atrial fibrillation and when a stroke occurs, or when somebody's in AF and when they have their stroke. So in studies where people had implanted cardiac devices of one type or another, pacemakers and defibrillators and so forth, and people are followed, we know when they're in atrial fibrillation or not, and we know when they have their stroke. And these studies have shown that there can be a difference in when somebody's in AF and when they have their stroke by as much as 30 days or more. In other words, it's not the case that if you're in and out of AFib, you're going to have your stroke when you're in the atrial fibrillation. It could be 2 months after your bout of atrial fibrillation, right? So this calls into question this idea that I think many of us learned in medical school, that it's specifically the fibrillating atrium that leads to the embolism. And even very brief runs, 20 seconds or so, can be associated with stroke risk. Probably not enough time for a clot to form. Similarly, people can have ectopy that may lead to a stroke before they go on to develop atrial fibrillation. So PR interval abnormalities or atrial premature contractions perhaps are associated with an increased risk of stroke even without atrial fibrillation occurring. Genetic mutations that lead to atrial fibrillation can also be associated with stroke risk even before they cause the atrial fibrillation. And similarly, you can have electromechanical dissociation of the atrium such that the surface EKG can look like normal sinus rhythm, even though the cardiac mechanics are displaying a physiology consistent with atrial fibrillation. So what we see as atrial fibrillation or not on the EKG may not reflect what's actually happening in the heart. So for all of these reasons, we would suggest that the connection between atrial fibrillation and stroke requires a new model, a new way of thinking about it. Again, we're taught in the US in medical school that the atrium is like a bag of worms when it's fibrillating, and it's that fibrillation that leads to stasis, clot formation, and going to the brain. If we think about Virchow's triad, right, it talks about stasis, endothelial injury, and hypercoagulability as being the triad that leads to clots. But, and I didn't know this until recently, the triad isn't meant to imply you have to have all three of those things for a clot to occur. You may need just one of them or two of them for it to happen. And so there are many other mechanisms of atrial damage that may lead to clot besides fibrillation. And they're listed here. You have fibrosis of the myocardium, you have inflammation, you have hypercoagulability potentially as a result. And all of these things may lead to embolism, even without there being atrial fibrillation. And so if we think of the traditional model of how vascular risk factors can lead to stroke, certainly we can get atherosclerosis and lots of other things along that kind of top pathway. We can also end up with an abnormal atrial substrate from high blood pressure, diabetes, et cetera. That can lead to atrial fibrillation, and that can lead to stroke. But we would hypothesize, and this is work that has also been done in large part by Houman Kamel, a close colleague at Weill Cornell in New York. But we would hypothesize that it could be that the abnormal atrial substrate itself can lead to stroke independently of the atrial fibrillation. So that's our hypothesis, and here's some evidence to support this. So I mentioned ectopy being another cause of stroke potentially. And so Human did a very nice analysis using the California Administrative Database. This is basically all admissions to hospitals in the state of California. There are millions of patients, right? And he looked at those who had a history of paroxysmal supraventricular tachycardia, but no history of atrial fibrillation, compared to those who had no history of either, no PSVT at all, and found that those with PSVT were at double the risk of having a stroke over time, okay? It's an administrative database, has many limitations, but suggestive that PSVT itself may be enough to cause stroke. Many of you may know that the EKG lead, V1, sits over the left atrium, or at least it should, and the terminal portion of that waveform goes below the median and is supposed to reflect contraction of the left atrium. And you can measure the depth and duration of that waveform and come up with a measure called P-wave terminal force in lead V1, and look at that in relation to risk of stroke. And so in the Northern Manhattan study, which again was a study that Dr. Massaro was involved in years ago, way back in the beginning, we had collected EKGs. Many of these were collected on those long paper strips that we used to use long ago before we had digital EKG machines. And we put she was then an undergraduate student at Columbia named Madeline Hunter. We gave her the task, she asked for it, but we gave her the task of going back to those old EKGs and measuring with the digital calipers the duration and depth of that terminal part of the P wave. I thought this was going to be a huge waste of time for a summer research project for this student, but she did the measurements and found that in fact those who had elevations in their P-wave terminal force were at increased risk of stroke, and specifically increased risk of unexplained or cardioembolic strokes that occurred years after the measurements were made. So something about that P-wave abnormality said that these people were at increased risk of future stroke. One can also look at biomarkers of cardiac dysfunction, such as N-terminal proBNP or cardiac troponin. And we have found that, for example, NT-proBNP is associated with risk of stroke. This was in the cardiovascular health study. And it was associated even after adjusting for atrial fibrillation, heart failure, and left ventricular hypertrophy, such that those in the highest quintiles were at increased risk of stroke. You know, again, years after the measurements were made. One can also look at the left atrial appendage. As many of you know, the left atrial appendage is the source of the clot in 95% or more of patients with atrial fibrillation. And the left atrial appendage actually comes in a variety of different shapes and forms. And this is some work that Shadi Yagi, who was a fellow with us at Columbia and is now at Brown University, has worked on. But you can see there are different shapes of the left atrial appendage. They come with fanciful names like chicken wing and cactus, windsock, and cauliflower. But you can imagine that people with a cauliflower shape, I don't know if cauliflower is in Portuguese, but cauliflower, the vegetable has all these like nooks and crannies in it. And you can imagine that blood clots could easily form in the interstices or the spaces within those shapes. And in fact, it turns out that patients with chicken wing morphology of the left atrial appendage are at the lowest risk of stroke in atrial fibrillation, whereas those with cauliflower are at the highest risk. And if you compare all the types but chicken wing, they're significantly at increased risk. So something about the morphology of the left atrial appendage may play a role as well. And so we would propose that that 30% that is found to have atrial fibrillation in a trial like Crystal AF represents the tip of the iceberg, perhaps a little bit of the iceberg underneath the sea is explained by occult AF, but then a big chunk of it may be due to other atrial cardiopathies or abnormalities of the atrium, but short of or except for atrial fibrillation. And these can be assessed using measures like looking for other arrhythmias, the size of the left atrium, those P-wave abnormalities I showed you, blood biomarkers, perhaps genomics, gene expression profiles, and so forth. Now, in the last several years, people have taken the point of view that if these embolic strokes of undetermined source are in fact emboli from the heart, then we ought to be anticoagulating them just like we do for atrial fibrillation. And so this led to two very large industry-funded trials, the ESIS trials, one of which used rivaroxaban, the other used dabigatran. These are Navigate ESIS and Respect ESIS. These were patients in strokes with unexplained cause, no atrial fibrillation, and they were randomized to either aspirin or to rivaroxaban or dabigatran, depending on the trial. And as you can see here, neither study, large trials, right, 6,000, 7,000 people, neither study was able to prove that anticoagulation prevented recurrent stroke in people with unexplained strokes, kind of dismissing this hypothesis about ESIS being an embolic stroke. But we would argue that ESIS, perhaps it's like fever, right? You don't treat fever by giving an antibiotic. You have to find out what the cause of the fever is. And so this slide is a very nice one, again, from Human and Babak-Navi and others, showing that ESIS is made up of lots of different specific causes. And towards the left of the figure, you can see some of the cardiac causes, like atrial cardiopathy, silent MI, occult cancer perhaps, PFO. Those may benefit from anticoagulation, but then patients with other causes, like large artery atherosclerosis, that may not lead to a full stenosis of the vessel, or aortic arch atherosclerosis and other non-atherosclerotic arteriopathies, those may do better without anticoagulation with antiplatelet therapies. Again, a hypothesis. And so coming to the therapeutic implications of this, as we wrap up shortly, we can talk about a trial that is probably very familiar to Dr. Massaro, because I think he was at Columbia when Dr. Moore was in the thick of this. This was the WARS trial, really a landmark trial in stroke prevention. And Dr. Moore had the point of view, and during my training, I did my residency at Mass General, Massachusetts General Hospital, which everybody called Must Give Heparin, MGH, Must Give Heparin Hospital, because we anticoagulated all stroke patients. But Dr. Moore tested this idea in this trial in which patients with stroke, no atrial fibrillation, but they had stroke, they weren't getting carotid surgery or anything, they were randomized to warfarin versus aspirin. And unfortunately, it turned out that the patients on warfarin did no better. In fact, they did worse than the patients assigned to aspirin. So this actually was the initial kind of nail in the coffin of the idea of using anticoagulation for all stroke patients. But one advantage to the WARS trial was that there were blood samples collected and stored. And so many years later, together with Will Longstreth and others, we were able to go back and measure those blood samples, and we found that those who had NT-proBNP levels less than 750 saw no benefit to being on anticoagulation, and those with admittedly quite high levels, 750 or higher, did have a lower event rate, stroke or death, than those who were assigned to aspirin. So in other words, NT-proBNP could be used as a biomarker to distinguish patients who would benefit from anticoagulation. And this led us to design a trial called the Arcadia trial, or atrial cardiopathy and antithrombotic drugs in prevention after cryptogenic stroke. And this is together with Dr. Kamel, Will Longstreth, and Dave Tershwell at the University of Washington. And this is essentially a multi-center randomized trial of apixaban versus aspirin for patients with unexplained stroke, but they don't just have unexplained stroke. They have to also have atrial cardiopathy, right? So we're focusing in on one subgroup within that ESUS construct. It's an NIH-funded trial being run through StrokeNet. We do get the drug, as I mentioned at the very beginning of the talk, for free from BMS Pfizer. They do not pay for the trial, and we get some help with assays from Roche for the NT-proBNP measures. Our hypothesis is that apixaban will be better than aspirin to prevent recurrent stroke in people with unexplained stroke, don't have atrial fibrillation, but who do have atrial cardiopathy. Patients have to be at least 45. They have a diagnosis of ESUS. They can be enrolled up to 6 months after their stroke. And so they have unexplained stroke, and then they get screened by having this P-wave measure taken. So they have to have either an elevated P-wave terminal force in lead V1 above 5,000, serum NT-proBNP of at least 250, and the third criterion would be severe left atrial enlargement. They don't have to have all three of these. They just need one to be counted as atrial cardiopathy, and then they can be randomized to apixaban or aspirin, and our primary outcome is recurrent stroke of any type, including hemorrhagic, and for safety, we're looking at death and other forms of bleeding as well. As of today, we're actually up to 706 patients now. We expect to be recruiting for another year. Our target is 1,100 patients randomized. We've screened 2,600, so it turns out that about a quarter, this is what we had thought also, about a quarter of patients with ESUS will have atrial cardiopathy, at least using our measures, our biomarkers. So that's been kind of on targets. We're looking at just that 1/4 of patients with ESUS who seem to have atrial dysfunction but have not yet manifested atrial fibrillation. We have 145 sites enrolling in the US and Canada. We're still adding sites. We were set back a bit by COVID, of course. And we also have an ancillary study that's been funded to look at atrial cardiopathy and cognitive outcomes. I probably shouldn't have this slide here because I know I'm talking to a group of cardiologists as well, or maybe even primarily. But I like to say that if our hypothesis is correct and Arcadia turns out positive, then neurologists won't need to care about atrial fibrillation in the future because suitable biomarkers may replace AFib as a target of therapy. In other words, we won't need to put in an implanted device and monitor for 3 years to see if the person develops AFib. First of all, there's something kind of weird about that, right? You have your stroke today, you get your implanted monitor. 3 months from now, you have an hour of AFib, and somebody says, now I know what caused your stroke. We're 3 months after the stroke. Isn't it more likely that there was something wrong with the atrium all along, caused the stroke before, it caused the AFib now? The AFib is just another biomarker of the underlying atrial dysfunction. At any rate, it allows us to diagnose that problem earlier than waiting for the AFib to show up on a later monitor. Of course, that again is a hypothesis that we're trying to prove with this trial. So if we think back to C. Miller Fisher and the history of atrial fibrillation and stroke, we can speculate that perhaps this decade would be the decade of the atrial cardiopathies, although that remains to be seen. So let me just finish by thanking my colleagues in the Northern Manhattan study for some of the data that I showed you, Dr. Sacco, who's now at University of Miami, Madeline Hunter, Mira Katan, who I didn't show you her work. She's done some work in this area with us as well as colleagues from cardiovascular health study at the University of Washington, like Will Longstreth and others, and the team for Arcadia as well. And of course, our funding from the NIH, BMS, Pfizer, and Roche. And on that note, I will stop talking, and I think we have some time for questions. So thanks very much for your attention.
Thank you a lot, Professor Mitchell, to have you here and shed light in our neurology and cardiology here today. And I think Dr. Massaro wants to talk something to start our discussion.
Case? You want to show the case?
Yeah.
Yes. I just want to show a case, a very quickly case. Then my discussion is about the temporal relationship that you have talked about. It's a 72 years old female that she had, we presented a TIA with us, sensory motor, hypertension, dyslipidemia, but she had a cardiac surgery with mitral valve replacement. They have also made radiofrequency ablation of the atrial fibrillation, and they have also closed the left heart. So she had no more after that, any fibrillation, any atrial occlusion, and she had this TIA, and she had a motor signs. She was really, she arrived at the emergency room very quickly. So she had an unexplained acute renal failure after that, but she recovered. She was on anticoagulation at the time she had the presentation of TIA at the emergency room. The problem was, this was the echocardiogram of her. You see here how much of the, I'm going to show back, how much of the contrast, enhancement that should be the risk factor for emboli, the spontaneous contrast. So the problem was, we reviewed the appendix. The appendix was closed. So this high thrombogenic feature was in the atrium without atrial fibrillation. She was on the monitoring in Unity without a closed appendix, but she had this on anticoagulation. And she was in the Unity using enoxaparin. And more, this is a TCG that performed, the case was from Dr. Antonio Sergio, from one of our cardiologist colleague, but this is from Dr. Shu and Dr. Marcelo, who did the TCD, and we detect a lot of mass, should be microemboli, not only the ACA, but also brain circulation. So it seems that not only we have a marker of the TIA, but we have a marker that emboli was coming from this large atrium. So my question is, how much the thromboembolism, like in the cardiac, in the left, like if you compare the left ventricle, more they have the D-dimer, more you have thromboembolism. It's like your Virchow, trial. And how much, like the other cameras, like the atrial fibrillation, like we see here, more atrial fibrillation in larger and more severe ventricle. Maybe it's similar in the atrium. So that's my question. So how much we are seeing, not only in the early period, the atrial cardiopathy, but those cases that we are dealing today with large atrium, that we think is the atrial fibrillation, and maybe in not taking consideration for the thromboembolism from the other markers that we are not taking care anymore, like in the atrium, like D-dimer or BNP and others, to show the risk of stroke. So that's my challenging question is, like, we are looking for cardiopathy for early, but how the late period, with atrial fibrillation, the atrium already is a major source of emboli, like the ventricle is.
So I assume you're asking the full group here, and I've probably talked enough already. I'll just say that's a terrific case. Thank you for that, Ayrton. And I think it's a good example of what we're talking about, although this patient, of course, does have some other problems as well, which may contribute. So, it's not isolated atrial cardiopathy, if you will, but in the setting of, valvular disease and other issues that she seems to have. But I'd be curious to hear what the others have to say.
So thank you very much, Mitchell, for the excellent presentation and for the case, Dr. Massaro. She was anticoagulated with what medication?
Yes, she was anticoagulated after the surgery because she had the occlusion, the appendage occlusion. She was in the trial. She was anticoagulated when she had the stroke, the TIA, and she had the normal renal function. Everything was normal again. So she was a patient with a large atrium, close the appendage, with no AFA at the time we saw her. I'm not sure if she had before. But interesting, the cardiologist does not take much attention for, usually, we discuss, for this contrast enhancement that we see in the atrium. And this contrast is very high. And then we can prove that this contrast or something that is there is giving us emboli because we have the TCD. So that's the question. Maybe we had maybe the atrium is like the ventricle. Large atrium, large ventricle. They have more FA, but they have also more thrombus. They have more other factors together. And if we close the appendage that we are discussing today, maybe it's not enough. What do you think, Gisele?
What was she using? What anticoagulant? I guess that the question here is it worth trying to change the anticoagulation, the anticoagulant that she's using for another one? I know we don't have head-to-head comparisons with specific anticoagulants, but it might be a way to go, or to add an antiplatelet might be an option depending on the hemorrhagic risk. Yeah, and if the patient has atrial fibrillation, this I would like to hear from Mitchell. Is it worth trying to revert the atrial fibrillation?
She already had reverted because she had ablation.
Okay,
She does not have.
But was she indeed reversed?
She was reverted. She was not with atrial fibrillation in the unit.
Okay.
So that was our amazing case because we did not have atrial fibrillation. We have contrast enhancement, and it's a large atrium. And also, just pick here the question also for atrial cardiopathy is we had the discussion a few months ago about this, is how much the enlargement of the atrium and the numbers they are discussing today is important for anticoagulate a patient. You understand my question? Like if you see during investigation of a stroke case in a large atrium, how much you consider large and how much you consider alone, without atrial fibrillation, how much you consider this case to be anticoagulated?
I guess that Arcadio is going to answer us this, isn't it, Mitchell?
The question, because this is your main idea is atrium. The atrium is the source.
Yeah, I'm sorry, are you asking me? I couldn't tell if somebody else was planning to answer.
No.
Yeah, so I think that the last question was how much of an enlarged left atrium is enough for you to anticoagulate a patient? And I've just kidded with you saying, you know, Arcadio is going to answer us this probably. Yeah.
Right, we hope so. Yeah, I mean, that's right. I think we don't know the answer. And in managing a specific patient like this one, we have to make inferences from the available data. And given the presence of spontaneous echo contrast, if that's in fact what we see there, I think that would be a patient where I would feel comfortable anticoagulating in the absence of some major bleeding concern. But I didn't say this, but the second hypothesis of Arcadia is to see if we can use those biomarkers. So we use a relatively low threshold for NT-proBNP. You know, I mentioned 250 as our target. And so we anticipate having a range of severities of atrial cardiopathy. And so it may turn out we'll be able to answer questions like this. Which biomarkers, what levels of biomarkers, and what combinations of those three biomarkers will be associated with the biggest benefit from anticoagulation and the lowest risk. And I would add that we chose our biomarkers based on epidemiologic evidence of their association with risk of stroke, but we don't know if we chose the right biomarkers or the best biomarkers. And so it may turn out that there are better ways. Maybe we should have looked at the PR interval or frequency of APCs or, PSVT or something else. And so I think there's a lot more to be learned about this, I guess I would say.
Mitchell, may I ask you one question? When are you measuring the main outcome at the trial? Were you worried about the results when you look at the RESPECT trial? It seems that after some times the curves do dissociate, and dabigatran seems to be a little better than aspirin. So did you take this into account when you design Arcadia? When are you measuring the main outcome?
Well, it's really measured continuously over time. There's no, all patients will be followed for at least a year and a half. So we plan to continue follow-up for a year and a half after the last patient is enrolled. Some patients will be followed for 4 to 5 years. So we will be able to see if there's a change over time. We assume, as in most trials with stroke, that the risk is higher earlier after the first stroke and then will decrease over time after that. So we'll just have to see. I don't know when. Now we are measuring the levels up to 6 months after the person presents with stroke, and we've done some analyses that have shown, we do think after somebody has a stroke, their level of NT-proBNP goes up, right? But we have not found a dramatic effect like that, so that it remains fairly stable over time after the stroke. So that's reassuring because it suggests that it's not just due to the stroke and then recovery and the NT-proBNP gets better. It seems to be measuring a more stable phenomenon.
Thanks again. I have just a cardiologist question. I think Arcadia will bring us many lessons and maybe some answers, and then we will know how to treat a patient with atrial cardiopathy after the first stroke. And how do you think we will treat patients before the first stroke? So we know the patient has atrial cardiopathy, so he has an enlarged atrium or maybe elevated levels of BNP. And when will we anticoagulate these patients? Of course, you need new trials, maybe atrial enlargement plus CHA2DS2-VASc or something like that. What do you think?
Yes, I think that's absolutely right. That would be the next logical step if we show a benefit to anticoagulating after stroke in patients with atrial cardiopathy, some sort of primary prevention trial using the same biomarkers or different ones. I think there were already trials going on looking at, device-detected atrial fibrillation and whether those patients should be anticoagulated. One thing I didn't talk about a little bit is, the burden of atrial fibrillation. There does seem to be a relationship between how much AFib somebody has and their risk of stroke. And of course, cardiologists, I think, are skeptical when, neurologist puts in a monitor and the patient has 10 seconds of AFib. I think many of you would say, well, that doesn't count. That's not atrial fibrillation. I don't worry until you have at least 30 seconds or 5 minutes or 6 minutes. And the neurologists, if the patient has 2 seconds of what may be atrial fibrillation, we slap on the apixaban or rivaroxaban or whatever, because we think, we found the cause and we anticoagulate. So I think it's there's a lot to be answered about how much AFib you need and how much atrial cardiopathy one would need and what the right measures are to determine that. So a lot more to learn in this area.
Mitchell, thank you a lot for your time. And the point is we need each other, cardiologists and neurologists. And so I'm looking for your next participation here. Thank you a lot.
Thank you very much. I enjoyed being here. Have a great day.
Thank you. Have a good day.
you.